Hello guys, Dr. Shubham here. So today we are going to discuss about a very important topic, that is the physiology of cardiac conduction as well as bradyarrhythmias. Because of the vastness of the topic, we have divided it into the three parts. Today we will discuss about the bradycardia and pacemaker. In the next session, we will discuss about the antiarrhythmic drugs, and then in the next session we will discuss about various types of tachyarrhythmias, and maybe a few points about the ICD or defibrillation will cover along with it. So now, any cardiac cell, they have two types of any cardiac cell, any cardiac tissue, they have two types of cells. One is the pacemaker cells and other conduction cells. So these pacemaker cells, these are present throughout. They are present in SA node, they are present in AV node, they are present in bundle of His, they are present in Purkinje fibers. What is special about it is that they have a special slow sodium channels, which we also call it as a funny current channel. And in this, the SA node has the highest automaticity, though every conduction node has an automaticity, but SA node has the highest, and that becomes the dominant pacemaker. If SA node is destroyed, then the AV node will become the next pacemaker, and it is regulated by a parasympathetic system, that is by the autonomic tone. Now, as you can see in this pictorial diagram, that there was a resting membrane potential of 60 millivolt. Now, what has happened that at 60 millivolt, there has been the opening of the slow sodium channels. So all the sodium has come in, which has led to depolarization. Along with that, there is the opening of fast calcium channels, which have led it to the fast depolarization. Once the peak has reached, then there's an opening of the potassium channel. The potassium leaks out and there's a phase of repolarization, right? Now, in the next pictorial diagram, we'll see the various channels. I've told that slow sodium channels will come. Then our your transient calcium channels will come. Then the long-lasting calcium channels will come. That will lead to the rapid depolarization. Then there will be opening of the potassium channel and the closing of the calcium channel. And this is how a pacemaker potential is generated. The next cells we have is a conducting cells. They have a persistently open sodium channels, as you can see from the diagram that there has been a persistent opening of a potassium channel. But along with that, what has happened that along with the opening of the sodium channels, there has been also the opening of rapid sodium channels, which has led to the rapid depolarization. Then again, there is a persistently open potassium channels that has led to the mild repolarization. And then there's a opening of a slow calcium channel, which has led to a plateau phase or a plateau potential. And then there's have been a persistent opening of potassium channels. Due to that, you can see a depolarization. What is special about the conducting cells is that they have a plateau potential. Now, this is how you can see that, along with the which channel is opened where. There the sodium channel opens, then the calcium channel open, and then the potassium channel open. But there has been a persistent opening of a potassium channel, और उसके साथ साथ sodium और calcium channel भी खुलते रहे. Now, these are the average durations of different intervals. The PR interval denotes the atrial depolarization and the conduction of AV node, and it is 0.12 to 0.20 seconds. Then we have a QRS duration, which represents the atrial repolarization and ventricular depolarization. And it has a range of up to 0.10 second, that is 3 small squares, 3 to 5 small squares. Then we have a QT interval that is up to 0.43 seconds. So we calculate the corrected QT interval. We divide the QT by under root of RR interval, and we get the corrected QT interval. QT interval is what? It is nothing but the ventricular depolarization and repolarization. And then we have the ST interval. What is ST interval? ST interval is a ventricular repolarization during the T wave. Now, there are two things. One is the ST segment and one is the ST interval. It will be more clear from the next diagram. In the next diagram, it will be very, very clear that how this has happened. Okay. Now you can see the PR interval from the start of the P wave to the start of QRS complex. It's a PR interval, and then we have a PR segment from the end of the P wave to the start of QRS segment. Then we have a QT interval from the start of Q wave, from the start of QRS complex till the end of the T wave. And then we have the ST segment, that is from the end of the QRS segment to the QRS complex to the start of the T wave. And then we have a ST interval, which will also include the T wave. 1 square is equal to 0.04 second. Okay. Now, we have different kinds of arrhythmias, bradyarrhythmias. What is bradyarrhythmia? Bradyarrhythmia is when the heart rate is less than 60 beats per minute. Okay. So when your heart rate is less than 60 beats per minute, it is known as bradyarrhythmia. It can be sinus bradyarrhythmia, it can be sinus arrhythmia, sinus pause, sinoatrial exit block, AV nodal blocks, AV dissociation, hypertensive carotid sinus syndrome. It can be a sick sinus syndrome. Okay, now we'll study one by one. Sinus bradycardia, it can be a physiological and pathological. Physiological, it is seen in athletes, it is seen in pregnancy. Pathological, it is seen in some degeneration of SA node, AV node. It is seen when there is a drugs such as the beta blockers, the calcium channel blockers, then acute MI, which will have a better prognosis if there's a bradycardia. Then in the post CPR phase, increased vagal tone, reduced sympathetic tone. How the ECG will look like? There will be a normal P wave, which will be followed by a QRS complex. Okay, see, there's a normal P wave, which is followed by the QRS complex. And there, how many squares? We can see 1, 2, 3, 4, 5, 6, 7. So 7 squares we have, a large squares. So that indicates a bradycardia. Per se, pacemaker is not required, but temporary pacing is done via transvenous electrodes, and permanent pacing is done in chronic sick sinus syndrome. Then we have sinus arrhythmias. So these are the patients which come most commonly to the OPD, and we usually misdiagnose it as some kind of a bradycardia, or the patient needs a pacemaker because there's a irregular RR interval, but that is not the case. In this, the bradyarrhythmia is occurring because of inspiration and expiration. So during inspiration, just look at this diagram, that during inspiration, there is a SA nodal acceleration. So our RR interval has shortened. But during expiration, there is a SA nodal deacceleration. So our RR interval has prolonged. And it is a normal physiology. Okay. So you can see the diagram that there's a difference in RR interval, but this is not any kind of a pathological bradyarrhythmia. Then we have a sinus arrest or a sinus pause. What is sinus arrest? When there's a failure to get discharge, there's a SA node. So what will happen? That there will be a phase of complete ventricular systole and the absent depolarization. In simple words, इसका मतलब ये है कि there will not be one P wave and the QRS. उसके बाद दोबारा से the wave will regenerate. ठीक है, ये कब होता है? ये होता है MI के पेशेंट्स में, degenerative changes में, any digitalis toxicity, stroke or excessive vagal tone. It is very common. And only the pacing is required when there is a symptomatic or a sinus pause for more than 3 seconds. Okay. So we have a sinoatrial exit block. In sinoatrial exit block, it's a type of a conduction disturbance, again due to excessive vagal tone, myocarditis, infarction, or some kind of a fibrosis. It also occurs due to quinidine and procainamide, and also in a digitalis toxicity. They have been classified into type 1 block, secondary block, and the tertiary block or the third degree block. Second degree block is similar to the AV block, Vancke-Back phenomena, but there will be a PP interval will progressively shorten, and duration of pause is less than 2 PP cycles. That way it will be more clear when I'll show you the ECG of this. Then we have a type 2 secondary second degree SA block. In this, there is no PP shortening. There is no PP shortening, and that will be coming at equal intervals. It will be more clear from this ECG. Now you see second degree type 1 Vancke-Back AV block SA block. In this, you can see the PP interval is continuously shortening. It is 0.8 second, then 0.80 second, 0.72 second, then a drop of P wave, and then again the normal wave will come. But in this, the PR interval will be fixed. It will not be prolonged, just as it is prolonged in the type 1 AV block, which I will discuss further. And now you see at type 2 SA block. In this type 2 SA block, you can see that your PP interval is still the same. But what is happening? PP interval is 0.86, and then there's a missing of a P wave. So in this, per se again, pacemaker will not be required in asymptomatic cases, but it will be required if the patient is symptomatic. Third degree AV block, there is no correlation again. Now, see, AV blocks, the most common site of a block is AV node, bundle of His, or bundle branch blocks. Now, the first degree heart block, such will be the picture that all the P waves will be followed by the QRS complexes, and the your PR interval will be more than 0.20 seconds. But all the P waves will be followed by the QRS. On examination, what you will find, there will be long AC waves on the JVP, and because of the prolonged PR interval, you will have a muffled or a soft S1. So yeah, one more thing is there. You can also see the abnormal QRS complexes in this because there is a block as AV node and bundle of His. Now coming to the which we are concerned about and which everyone is very much keen to find, that is a type 2 second degree type 1 AV block and second degree type 2 AV block. It's called Mobitz type 1. There's a periodic failure of conduction. What will happen? There will be a progressive PR interval lengthening, and then there will be a missing of a beat. I will see the picture. You see, there's a progressive PR interval lengthening, and then there's a block. If such is the picture, that means the site of block is AV node. Now you look at the second degree type 2, Mobitz type 2. In this, it's an intermittent failure of P wave conduction without PR or RR changes. It's a more distal block. That means it is more of the block in the Purkinje system. So there's a constant PR interval and there's a block 3:2 conduction, and they have a poorer prognosis. Management, again the management, you put the patient on temporary pacemakers for 72 hours and then you put the patient on a permanent pacemaker. Then the complete heart block, there is a no synchronization between atria and ventricles. Both are moving at their own pace. What will be the symptoms? The symptom will be of the cardiac output failure, palpitation, syncope, left ventricular failure, and the block can be at the AV nodal level or it can be at a bundle of His level. If it is at a AV nodal level, that means a congenital block, and if it is at the AV nodal level, it's a your acquired block. What is the management? You give a short-term vagolytic therapy with atropine. You can also try a catecholamine isoproterenol, and temporary pacemakers are preferred. And if it is not successful, treatment of choice is the permanent pacemakers. So this is a complete heart block. If it is at a congenital, it will be at the AV node. P wave is not followed by QRS complexes. There will be a ventricular depolarization preceded by bundle of His. Normal QRS complexes, better prognosis, but acquired at the distal to His bundle, which will have a poorer prognosis. Now, AV dissociation, again, the P waves and QRS are independent, but in this, the P wave morphology is different. In this, the P wave morphology is very, very different from each other. Then we have a hypersensitive carotid sinus syndrome. What happens in the hypersensitive carotid sinus syndrome? So what will happen? There's a phase of ventricular asystole caused by cessation of atrial activity from a sinus arrest or SA exit block. It is most commonly seen with a coronary artery disease. It is cardio-inhibitory or vasodepressor. Cardio-inhibitory, there's a phase of ventricular asystole for more than 3 seconds during the carotid sinus stimulation, and there's a vasodepressor. There's a fall in SBP to more than 50 mm. And this is a very sick state because you cannot give propranolol, clonidine, methyl dopa. And for cardio inhibitory, you can try atropine, and for the vasodepressor, you can give elastic hooze and a sodium retaining drugs. Sick sinus syndrome, when there is a destruction in the destruction of the sinus node due to blockage in the sinus nodal artery, there will be a fibrosis and a fatty infiltration of the atrial wall. There will be a phase of a spontaneous sinus bradycardia followed by a tachycardia. So it is also called a brady-tachy syndrome. Pacemakers, we have two types of pacemaker. One is a temporary pacemaker, other is a permanent pacemakers. Temporary pacemakers is kept at the trial of 72 hours, and it is kept outside. There's no invasion, and we see the response of the patient. If the patient responds well, patient is discharged, and if the patient does not respond well to the temporary pacemaker, then the permanent pacing is done. So what are the components of the pacemaker? There's a generator which is placed subcutaneously or submuscularly. There's a battery which is made up of lithium iodide, which has a lifespan of 5 to 8 years. Then there's the endocardial leads, which is access to the internal jugular vein and put into the right ventricle, and leads are attached through the screws to the endocardium. Site of insertion, the most common is the right internal jugular vein. It can be in the left or a right subclavian vein, or it can be in the femoral vein. How we give it a nomenclature. It is according to 1, 2, 3, 4, and 5. 1 is the chamber paced, 2 is the chamber sensed, and 3 is the response to the chamber sensed. So it can be a chamber pace, could be atria, it could be ventral, or it can be atrioventricular chamber pace. Okay. So what are the complications? There can occur pneumothorax, cardiac tamponade, infections can occur. There can be a blood loss. There can be arrhythmias. There can be premature ventricular contraction. There can even be a bundle branch blocks. What are the contraindications? The patient cannot go for an MRI. He cannot go to the places with a very big magnets. But nowadays there are cardiac safe pacemakers which are being established, and they are very successful. One thing which needs to be kept in mind: if the patient dies before the lifespan of the battery, has completed, so the first option is that the family members can donate that pacemaker. Second, during the cremation, it is very important to take out the pacemaker before cremating, because there can occur a blast at the site of cremation. So if anybody have any doubt, they can ask me. Yeah. The dose of atropine is given. It is given 0.6 mg IV stat, and then again it is repeated after 5 minutes, and again repeated after 5 minutes. And if it is not successful, the patient is sent for the temporary pacemaking. If that is also not successful, then the patient is sent for a permanent pacemaking. So thank you.